So welcome everyone to this Requesting Changes to MedDRA. My name's Jane Knight. I'm a clinical associate and I'm joined by my colleague Dr. Eva Rump. I'm going to turn my camera off because it's distracting for the session. So the first slide just explains that MedDRA came about in the mid-1990s. It was an ICH initiative, and at the time there was an ICH MedDRA Management Committee put in place to maintain to oversee the activities of the MedDRA MSSO. The MSSO was put in place to maintain and distribute MedDRA, and all of the activities are overseen by the management committee with representatives from across the industry and the regulatory authorities. The next slide is a copyright notice explaining that the material we're going to use today is, just like MedDRA itself, is property of ICH. If you use it, you must acknowledge ICH and as owners of the material, and if you change it in any way, you need to explain how you've changed it. This is what we're going to cover today. We're going to start by briefly explaining how you request a change and the process, both for you and us internally. We're then going to highlight how the proposals are considered, and we're going to do this with a number of examples that you can vote on. We will describe elements of a good submission and then look at some examples. This is how you can join the quizzes or polling. You can do it, the easiest way is to scan the QR code with your mobile phone, but if you can't do that, you can join with a browser, either on your computer or your mobile phone. You open the browser and you type in pollev.com at the top in the URL field. So do this in Chrome or Safari or Edge, just in the URL field, and then when you get the screen on the right hand side, you enter my name as the username. This will join you to the presentation. It's completely anonymous. You don't need to put your own name in. If you put my name, then it will link you to the presentation. And if you forget how to do it, the details are in the chat and I can show you the QR code at any time. The first example here is, where are you joining from today? So let us know. Show us on the map where you're joining from. Oh, we've got quite a number of you from Europe there. Africa, India, Korea. Across Europe, it's very small to see.
Oh, South Africa.
South Africa. Somebody's moved, it's hard, isn't it? Welcome. Welcome, wherever you are in the world. So getting on now to our process. So MedDRA is updated twice a year, as you know, and with each new release, users can request changes, and we call these change requests. This is part of your subscription fee, has no additional fees, and these change requests can be for new term additions or modifications to existing terms. And if you do make submissions, you do it via a tool called WebCR. This is an online tool, a portal that allows you to enter your request and comes through to us. This is where you access the tool. So it's on our website, and if you click on the How to Use button, that will take you to the change request page. You see there the process that I'm going to explain, and you see there the link at the bottom right hand side to take you to the WebCR tool. There are some documents there that can be useful to you, information about how to use the tool and some considerations. There's also a note there about the freeze dates. So when you click on the tool, you see the freeze dates again mentioned here. So Eva, did you want to share with us the group the importance of the dates?
Yeah, certainly. So you see we have two freeze dates, and the one for the major release in March is 1st of December. And this is pre-Christmas time, but that's not all. So sometimes we get change requests from a company about 50 changes, which is the limit. But if you consider that we have thousands of subscribers, so if everyone only send in the change request the last minute. So it's too much for us, and the quality may go down because we are a small team and we cannot work 24 hours. So please, if you send in change requests, please do not collect everything from your company until the last day, because it's too much work and the quality, as I said, may go down. Okay.
Thank you, Eva. Thank you very much. So the 1st of June is the date for your diary. You've got a month, just over a month, to get in any new change request you'd like to submit. This is the change request tool that I mentioned, and I've got put the links on the screen here for the quick start guide and the guidance documents. The important thing you need to remember here are the passwords for logging on. Now, if you're asking for one of the terms, the translation to be changed, one of our translated versions, then you use your MedDRA ID and your web password. But if you're asking for a change to the English version, then you use your MedDRA ID and you use a specific password for change requests that we call the change request ID. Now, this is not made public to everyone in the company, so you may need to contact your point of contact. And if you don't know who that is or how to get it, email us at the help desk and we'll help you. So for translation requests, you can use either the change ID or the web password. But if you use the web password, you can't make any changes to the English version. That's a little bit of anomaly there that you need to bear in mind. There is also an instructional video, so if you forget the information today, you can go to our training section and look at the instructional videos. There's a video cast of how to submit a change request, and that's available in a number of languages. This is the process that follows then. Once you've sent your change request in, it's qualified, verified. You then get an acknowledgement, an email that it has been submitted. Now at that stage, you don't know the decision, but you know it's been submitted. One of our team will pick it up and perform what we call triage. This is an initial view of the request. And one of our international medical officers will then make a proposal based on what you've submitted. There's time for all of the rest of the team to review the proposal together with your rationale. And then they have a call that Eva's part of the team to discuss the request, and a decision would be made. You're then informed of the decision, and if it's approved, the term, if it's added, it becomes a supplemental term. That means that it has been approved and it's waiting for release in the forthcoming version. So this is the whole process. We have a triage step, and then we have a consensus where international medical officers review and discuss your request.
Jane?
Yes.
May I? Can you go back to the last slide? So sometimes if we have questions for a subscriber, the subscriber will be contacted by someone from our main office. So in general, we are blinded, so we don't know who is submitting a change request. And so we are completely blinded, and our individual judgment is based as well blinded. So I never know what my colleague in Spain, US, or Japan is judging. So we all are blinded and do our judgment independent from each other. And only in the consensus call we know all the comments, and then we make our final judgment. Okay.
Thank you. Perfect. Thank you, Eva. It helps to have the insight. This is your opportunity to send your questions or comments into Eva while she's with us today. So do take that opportunity of putting your questions in. When the team review your proposal, there are 4 possible actions that they can take. This is 4 decisions that could be made on it. The first is to approve it exactly as you've requested it. That might be the spelling or the placement or the wording of the term as you've asked for it. Or alternatively, the team might agree with you, but it's not exactly as you request it. And we'll see some examples of that. They might change the wording or the phrasing of the term or the placement that you've proposed. Sometimes they don't, for whatever reason, the request can't be approved, so it's not approved, not accepted. Or sometimes the team will put it on hold, what we call suspended, to allow more time for discussion. And this is what Eva just mentioned, either with you as the subscriber or with one of our colleagues who may be more of an expert in that area. So this is the options. These are the options available to our team. The considerations for our international medical officers are supporting your needs, but also the stability of MedDRA, the impact on legacy data, and making sure that the changes are useful to all subscribers. So by this, sometimes we might receive requests which are very specific to a particular therapeutic area. And if it's an internationally recognized and widely useful change or addition, then it could, and if it's within the scope of MedDRA, then it will be added. But sometimes if you're asking for changes which impact MedDRA in a way which is only useful to your area of work, we're not able to do that. So that's just some of the considerations. The terms themselves need to be clear and unambiguous. They need to fall within the scope of MedDRA and be something that's new. We're not looking to add existing concepts. We do sometimes add synonyms if they would be useful, but we don't add terms just because you want to see the wording in another order or you're doing what we might call cosmetic changes to terms. We don't encourage due to combinations. We have some terms in MedDRA already. Remember, MedDRA has evolved over a very long period of over 20 years, but we don't have due to new combinations of terms. We like the terms to be single medical concepts that are universally valid, internationally recognized. If they're a concept or an abbreviation, they need to be correctly spelled and fit with MedDRA conventions. And if you want to see some of these conventions, you can find them in the introductory guide to MedDRA, some of the rules around the structure of MedDRA. As you know, the spelling is American English and British English at the LLT level, but only British English is used for the PT level. In terms of capitalization, it's only the first word capitalized, unless it's named after an individual or it's an acronym. And placement of the abbreviations, they're usually at the LLT level, with the exception being CSF, white blood cell count, blood cell increased. So these are the documents that could be useful to you. There's one, I mentioned the introductory guide, because this has information about the structure of MedDRA and the rules around it. We also have the change request document that will give you some guidance on how to make change requests. That's useful reading following up from this session today. So, having said all that, Eva, let's get on to some of our change requests and let our group have the chance to experience what it's like to be one of our IMOs. So here's the first example. The request was to add a preferred term of acquired laryngocele. And the rationale we received was that the company had received the term acquired laryngocele for coding, and they gave us a reference, and they pointed out that although more commonly congenital, it can be acquired, and the example is with glass blowers due to continual forced expiration, which produces increased pressure in the larynx, leading to a dilatation of the laryngeal ventricle. So this was the good rationale there for the request. So now if you were on our team, what would you propose? Acquired laryngocele. Would you approve this one? Hopefully you can. Yeah, it's working. What would you do? If you want the QR code, I'll just put it here so you can see again. If you haven't joined us on the poll, scan the QR code. It'll take you to the website and you can directly link in. Okay, everyone got that? Do join us because it makes it a lot more fun for the session. So it seems like most of you would approve. Some of you would approve, 50-50 really. Approve as requested seems to be the most common decision there. A few of you are approving not as requested, but generally it seems like you're favourable to the proposal. So let's have a look, Eva. Look, it was approved as requested. Now tell us more.
Yeah. Okay, so first of all, this was a very good rationale from the subscriber and very polite and very helpful for the decision with the glass blower example. And so we appreciate it. This type of change request is very much appreciated, and not term is not in MedDRA or only providing a reference. So here it's clear. Usually laryngocele is a congenital issue, and in rare situations it may be acquired as well. So we accepted the proposal, and it was added as a PT under HLT in the respiratory sock only. This is a very important information. We often do have things which usually are either congenital or acquired, but some rare decisions are, some rare situations are for the opposite situation. So we do have both in MedDRA, but not all the time the terms are at PT level qualified with acquired or congenital. And Jane, can you add aplastic anemia in, just to show you how important it is? So we have aplastic anemia, we have acquired and on LLT, and we have congenital. Let's look where congenital aplastic anemia links to the PT level. So this is a PT congenital, whereas acquired aplastic anemia, can you click acquired aplastic anemia, is going to the PT aplastic anemia to the, and it's only in the sock for blood. Yeah. So you cannot expect that all terms which can be both are having the qualifier acquired or congenital at PT level. So if you have such a situation, a report where it's just aplastic anemia, this is, and in the history, you know, it's a congenital one, but the PT aplastic anemia only links to the blood sock. So this is very important to make sure if you have terms which can be both. So for example, limb asymmetry, of course, can be connected with many congenital malformations, but if you have an injury and resulting out of having one leg shorter, then it's not a congenital. And this is very important because of the teratogenicity. So if you have data, cumulative data, and then you have congenital terms, which in which are not congenital, but you miscoded it because you didn't look at where the terms, the unqualified terms go to, then you may have a problem with your data analysis.
Thank you, Eva.
Jane, do you want to add?
The plain term here, what you're saying then, the plain term will always go to the most common occurrence. So if aplastic anemia is most commonly acquired, then that will be where the plain one is placed, assuming it's acquired. Assuming it's and vice versa.
And this is one of the MedDRA conventions. You just have to know that the most common type goes without qualifier at PT level, and not having necessarily always the qualified LLT underneath.
Plain one, unqualified. Thank you. So let's have a look. There's the placement there. Just to summarize for you what we've shown you in the browser, you can see clearly there that the congenital is in the congenital as the primary and the respiratory is secondary, whereas the acquired of laryngocele is in the respiratory. So exactly what we've just seen. So here's our second example. It was a request to add a PT of tattoo reaction. And here we have the rationale that a delayed hypersensitivity tattoo reaction has been reported after the use of immunomodulatory therapy. The specific reaction can't be captured properly with the current MedDRA terms, and the requester gives us a reference there from medical literature. So what would you do if you were on our team? What would you do with this request? Would you approve it? Or would you change it in some way? Oh, we've mixed now. Would you approve that one? You can test yourself against what the, oh, and someone's going to change it in some way. Interesting. Again, mostly our group were going to approve it as requested. A good rationale again. So let's see what was actually done. The outcome was that it was approved, but not as requested. So what did you change, Eva, about that one?
Yeah, so tattoo reactions are very important because more and more people get tattoos, and yeah, complications getting out of it is a common scene. But we had to modify it because based on what subscriber told and based what we have found, we needed to modify to make clear we talk about the skin reaction. So tattoo, the chemicals in tattoo may cause even very severe systemic complications, including yeah, on our immune reactions, iridocyclitis and so on. So we wanted to clarify that we talk about the skin reactions, which most often are either inflammatory or allergic. So, and some of the components in tattoo inks are even on the list for carcinogenity. So that's what we did with this tattoo reaction. And we added, because it's a skin reaction, we could add it to dermatitis ascribed to specific agents. So it's the local, the skin reaction. Okay.
Thank you very much. Thank you. So well done to those of you that thought it could be changed in some way. The next example was to change a term from being current to non-current, and the request was to make the LLT cramps non-current, with the rationale that it's colloquial and coding practice shows that the term is most often used to describe abdominal cramps. Well, that was the view of the submitter. Therefore, it's not appropriate to code vague cramps in the absence of more information or context to muscle cramps. So what they're saying is the placement of this is to muscle cramps, and they'd like to flag it as non-current. And here, just for your benefit, you can see what they're talking about. Here's the LLT cramps with a PT of muscle cramps going up through the muscle disorders to musculoskeletal and connective tissue disorders, SOC. So you can see there it's a muscle cramp. So the submitter was asking that because they most commonly see it with abdominal problems, abdominal cramps, they'd like to make it non-current. So what would you do with this one? Not approve seems to be the first decision there. Somebody's in straight away. They're not sure about that with cramps. Anyone else got views? Somebody would approve it. Or suspend it. Interesting, for more discussion. Interesting, Eva, isn't it, to see how our group... Anyone else got thoughts before we show you what really happened?
Yeah.
Mix. Generally not approving seems to be the overwhelming there. So the outcome is that you're right, it was not approved.
Yeah, which makes us happy because flagging old terms non-current, which are in MedDRA since beginning, like the grams, may have a huge negative impact on legacy data and data analysis as well. So grams as such, okay, is a synonym of spasms, and we do have spasms all over, yeah, laryngeal spasm, abdominal spasms. But before we go further, can you add in the TM Lab?
Yes.
Change request history? I think you did it already.
Here we
And
are.
add
So this is the tool you use,
grams.
Eva. This is how you do your daily work, isn't it? This
In plural. Add it in
cramps.
plural.
Cramps.
Yeah, grams.
Cramps.
Okay. Okay,
Let's have a
so
look.
flagging things non-current is always a problem. So before we do our own, yeah, of course, cramps and spasms can happen everywhere. Why was it placed under muscle spasms? Because that's the most often context. Cramps, I'm having cramps in my leg, in my arm, and so on. So in 2.1, it was added, meaning it was a legacy term coming out from company databases, but as well from regulatory databases. And this is how in data analysis, cramps as such is used always. So you see, we got in version 14 already the change request to flag this non-current, and we rejected. Now it comes back again, and yeah, and we rejected it as well. So now can you go to the browser and add the spasm, or cramp spasm?
Would you like spasm?
Spasm, yeah.
So here we are, we've got 138 terms for spasm.
Yeah, so you see everything which is not muscle spasm and going to somewhere else is having the qualifier or the anatomical qualifier. So facial spasm, glottic spasm. So, but the cramp alone or spasm alone goes to muscle spasm. And this is just what's most commonly used, a lay term. Okay, it is lay and it may be ambiguous, but it's used, and flagging this non-current may have really a huge impact, including on SMQs, because if a term is part of an SMQ and gets flagged non-current, then this may mix up the data from people as well.
So it's not just abdominal, is it? We can see here that it's there are a lot of terms covering it with different legs, and it's not always abdominal cramps.
Yeah, and sometimes spasm and cramps go to pain, or the menstrual cramps,
bladder pain there, menstrual cramp, uterine cramps is a spasm. Premenstrual cramps is pain again. So it's a mix, isn't it? It's pain, spasm, depending on the part of the body.
Yeah. So playing around with the browser may help you either to avoid a change request or going to the right direction. So here, cramps keeps current.
Good. Thank you, Eva. And I think our group generally agreed with us there, which is very good to see. The next example we had is to add a new term. It was asked to be added an anality of cervical vegetation. And the rationale given talks about neoplasms caused by the HPV virus infection transmitted through sexual contact, particularly in young women. So they're talking about neoplasms here, but they're called with the term of vegetation. And they give us a description that the surface uneven and verrucous. Some symptoms may include itching, burning, pressure, and so it's all about the HPV virus here as a cervical neoplasm. So what would you do with this one? Cervical vegetation. What would be your thoughts on that? I know that you've not had time to research, as Eva and the team would do, but what would be your first thought when you see that? If you were doing triage, what would you propose? Not as requested seems to be the first thought on that one. So our subscriber did give us a document, a reference for it, which is always a good thing to do, to give us a PDF, a reference. But unfortunately, it wasn't in English. And that's something, because our team are international, we need the references to be sent in English. So overall, the decision there is that our group are not sure about this one. and the outcome was, you're correct, again, it was not approved. Eva, tell us more.
Yeah, so I would be interested in the attendees who voted accept not as requested, so for the alternative. So if someone wants to put it in the chat, it would be nice. But vegetation in the medical use is outgrowth, overgrowth, mainly bacterial, or a cell proliferation, which can be malignant, and so on. So, but having said this and reading what subscriber pointed out, the neoplasm on the cervix, it was clear we talk about probably different things. The only vegetation terms we have in MedDRA is the adenoid vegetation, which is the hyperplasia of the adenoids. Then we have divide lead vegetation, meaning the vegetation, the overgrowth with bacterial, and the same is the third example is cardiac valve vegetation. So, but in the area of the cervix, using vegetation is too dangerous. Where would we place this? Under which? Under the cervical neoplasm. We do have the pap smears. We do have cervical intraepithelial neoplasia under cervical dysplasia. We have the cervicitis with the human papillomavirus, and we have the cervix wart. So caused by HPV 6 or 12, which are the condylomata. So it was just too dangerous and too vague to place the cervix or cervical vegetation anywhere in MedDRA to be sure we did the right thing. So we rejected.
Thank you very much. It was rejected and our group agree with us. So let's have a look. Now, next example is to add the LLT of scalp hematoma, typically appearing as a bump on the head, the damage to the external skin and muscle, so it won't affect the brain. And they also talk about septal hematoma, can cause nasal problems. But this one we're talking about is scalp hematoma. Scalp hematoma with the spelling, you've seen the spelling there. They've asked for it to be an LLT. So what would you recommend for this change? Let me show you the QR code. Manal was asking for it. There we are. If anyone needs the QR code on that one. And we've got a comment in. Martin's just pointing out that this area has natural vegetation anyway. So that's another reason that it's not clear really what the problem is with the requested term on that one. It might be a translation issue, as I say, because the reference came in it wasn't English. So it might be something which doesn't translate very well. So this one, scalp hematoma, predominantly our group would approve as requested. A few would change it. Interesting. It's always interesting if we have the option to know, what do you mean? Why? How would you change it? Those of you who would change it. So let's see what the outcome was. Hopefully everyone's got the chance now to vote. It was approved, but not as requested. So the 18% of you were correct there, agreed with us.
Yeah, okay, but only because of the capitalized hematoma. That was the only issue. So,
leaky. So let me show again, Eva. It was requested with both words were capitalized, and that's not one of our conventions. So that's the difference.
Yeah. Okay. If you want to avoid approve not as requested, talking about British English versus American English, you have the option to only request term. So if you, and not add a LLT or add a PT. So this may increase your percentage of acceptance as requested, but this is peanuts. Yeah, but still, we need to say approve not as requested because it's not correct.
And it was added as a PT with the British English spelling, and the term that was requested was, of course, added as an LLT underneath it as well. So we see that there in the highlighting. And here we see it. It's in 3 socks vascular is the primary, but it also has a link to injury as a hematoma and pregnancy from birth trauma. Yeah. So interesting, I think, to see the placement of that one.
Yeah, scalp hematoma in neonates is actually the most common situation. That's why it needs a link to pregnancy shock.
Interesting. I sometimes wonder where the pregnancy shock gets used, but that's a good example of it. Thank you. So looking now at what makes, we've mentioned a few of these. So focus on the wording of your term. Pay attention, as Eva says, you can use the browser to help guide you in where you could ask the term to be placed based on other similar terms. Look at the MedDRA structure, and you can see that in the browser or read about it in the introductory guide. Give us a rationale, because that does help. Sometimes it helps us to understand what you're asking for. And then bear in mind, ask yourself, is this really useful? Will this be helpful to other subscribers? Not making sure it's not just something that you found a very specific thing and you think, oh, I'll ask for that because it's not in there. Make sure that it will help your analysis within your company and potentially help other subscribers, rather than wasting your time and our time in submitting them. So that's just a consideration. We want to hear from you, but make sure that the change requests are useful to everyone. So all change requests do require a rationale for making it. This is describing the requested change, explaining the specific need for it. And as we've mentioned, it helps our IMOs in their discussions, and it may prompt them to consult with you for further information so that we can help you as best we can in the placement. These are some, Eva mentioned a couple of these before, where there is room for improvement. People have said to us, please add the term, the current primary SOC is wrong, this was reported for a patient, or this condition is not in MedDRA. Now I know, I can confess from my time in the industry, years back, I remember doing some of these myself, Eva, so it's very easy to do, but it helps you by telling us exactly why you need it. It makes it more likely for you to get the change request approved. These are some of the things we've already mentioned, explaining the need, make it anonymous. We mentioned this before. The team are blinded, so please don't tell us the name of your drug or the name of your company. We want it to be anonymous. The team are blinded to you and also to each other's comments. If you do have medical references, it can make it easier for us, help us, and you can attach those in PDF. And if you know the placement, you can add it as either an LLT or PT with the placement if you know it, but that's not essential. And as Eva said, you can just say add a term, and then you're less likely to be wrong as such. Here's an example of a good justification that the submitter was asking for PCDH19 epilepsy, and they explain that it's a rare epilepsy syndrome with early onset seizures, cognitive and sensory delays, and behavioural problems. And they tell us about the gene mutation, such that they also submitted another term. Oh, I'll tell you the answer for that one first. So that one was approved, but not as requested. It is a rare type of epilepsy, but why was it not as requested, Eva? Why was that one not as requested? Occasional company will be added as a PT.
The PT, yeah. So with this, we do have situations where we have rare diseases caused by a gene mutation or any other gene alteration. And therefore, this is very nice. So the epilepsy is there, and then the second one, they ask for the gene mutation. Okay, the gene mutation goes to a different area as the epilepsy in the hierarchy, but often people need to have both sides. So, for example, the breast cancers caused by hair, which is the human epidermal growth factor receptor positive, need a different treatment than if they are negative for HER2. So that means we do have in the congenital SOC the gene mutations, and we a few versions ago we modified the HLT names for some HLTs. So we do have here a gene mutation and other alteration for genes in the congenital, and then the related diseases are not linked to the congenital because they occur sometimes only in the adult time. And the same for, Jane, can you probably add the HER2?
Yes, in the browser.
In the browser.
Of course. So HER2 positive, HER2.
HER2 in, well, without space, I guess. Try.
Did it not have a, you'll search too many results.
HER2.
HER2, here we are.
Yeah. So you can click up the HER2 gene amplification, the first one, and then the breast cancer. Yeah.
See
so
that
here again, the
gene
gene mutation goes to the congenital, and the HER2 positive breast cancer is only linked to the reproductive and the neoplasm SOC.
You can see the details there on the right-hand side. Look there. So that one, the breast cancers in the neoplasms and the reproductive, but not in the congenital, whereas the amplification is in this one we see is in congenital. Good.
And can you, for the last thing, can you go to the HLT gene mutations in the browser? Just click on the gene mutation HLT.
In the congenital, here we are then. Chromosomal, isn't it?
Yeah, this one.
Gene mutations and other alterations, NEC.
Yeah. And you see how many terms we do have already. So some are red, some are blue. Yeah.
There's the HER2.
And this is a growing area in pharmacy anyway. So for drugs developed especially for gene modulation.
Good. So we go back to our slides.
Yeah.
Well done on that one. So here we go. We've got another one here. Good justification again with NSAID exacerbated respiratory disease. And the submitter asked us to add it under the PT aspirin exacerbated respiratory disease, which already exists. And they point out that ibuprofen-induced respiratory disease has raised the question of whether there should be a more specific term at the PT, such as NSAID exacerbated, with the aspirin should be at the LLT. So they're telling us really, ideally, they'd like them the other way round. But what they've submitted is to add it as an LLT to the existing PT. So that's interesting. But the rationale really does help again here by the reference and by the description. And the outcome of that one again was that it was not as requested because, as we just saw, they asked for it as a more general term under a more specific term of aspirin at the PT. Whereas here, what the outcome was what they asked for. Let me just show you, got the highlighting there, that the aspirin exacerbated respiratory disease was demoted and the new PT became NSAID exacerbated respiratory disease on that one. Exactly what they asked for.
Yeah. Okay. So in the justification, they ask for the right thing, but the command was the wrong. So they just and we have to focus on what's in the action line. So that's
why it was not as requested.
Yeah.
It's good. And here you can see that one was added and some others were added as well. What you're seeing here on this screenshot is a snapshot from the supplemental terms in the supplementary view in the web-based browser. Now, before the end, we will stop and show you how to view that. We've had a request from one of our subscribers asking us to show how they can see what has already been requested by other subscribers. So we'll finish a few minutes early and show you that if that's of interest to you. And I'm just going to have a look at the questions now, Eva. I can see we've got some comments about the mutations. Cancer mutations are often somatic mutations not present at birth. So although that's where we place them in the congenital sock, just to point out they can sometimes happen later in life, but they're still with the other mutations in that section. So just to see, any comments on any of those others, Eva? Do you remember the discussions when the other NSAID exacerbated disease were added?
Yeah, I think most of them have been already under the aspirin, but because they are now allergies, they are flagged now with.
They moved.
Yeah,
when the PT was demoted. They moved with it. I see.
Yeah.
I see. Okay, so let's have a look. I've got some more now, some more for you to join in. This one is to add a new term, and it's capillary fracture. Now, for me, this is one where if I didn't have the rationale, I would immediately think vascular. And it's only when I see the rationale, and this is why it is so important. Capillary fracture is a fracture that appears in the radiograph as a fine hair-like fracture, the segments of bone not being separated. So it seems like it's a synonym for a hairline fracture. And that was new to me. That's why I thought this was an interesting term, and it shows the benefit. So what would you do? What would you do if you were to vote here? Would you vote yes or no? Would you add this one or not? You can see here very visually how our group is divided, how much discussion there'd need to be to get consensus. So generally, there 3/4 of our group roughly are saying yes, they would add this term, the capillary fracture, because it comes with a good rationale and a reference, so why not? Let's have a look. Yes, it was approved as requested, and it is a rarely used synonym of the hairline fracture, and it was added. Anything you'd like to add on that one, Eva?
Yeah, this exactly is the point for rare synonyms of something. And like you, I first thought on the capillaries, and we do have a capillary fragility test in MedDRA. So, but with the explanation, I at least looked deeper into what they wanted, and I really found articles in Medline that it's a synonym of hairline, and hairline is a LLT under stress fracture. Yeah.
Thank you. Good. So the rationale really helped there. The next one was to add an LLT, KILIP class 1. And the submitter tells us that a classification of myocardial infarction characterized by an absence of rails over the lung fields and an absence of the S3 sound. So let's see here. Do you think this was added? Yes or no? Would you add that term? KILIP class 1. So it's some sort of classification system, seeing that class 1. Generally, no. Now, I wonder if that's to do with what they think is the scope of MedDRA, the classification, having another classification system, or is it international, I wonder? Generally, the group is saying no on that one, Eva. Interesting. And it was approved as requested. So tell us more about this one.
Yeah, okay. So we do add some classification terms, and if they are classified like here with KILIP class 1, it goes up to 4, then it's already a diagnostic term, because KILIP class 1 is acute myocardial infarction, but without the severe sequelae or the complications like pulmonary edema, or the last one is cardiogenic shock. So we internationally accepted and stable classifications are added in MedDRA as such, and this is why we added not only this one under acute myocardial infarction, but we added as well the KILIP classification in the investigation SOC. So same can can you see we do have the NYHA classification in MedDRA in the investigation SOC under cardiac function diagnostic procedures, but the single class 1, 2, 3, 4 are under cardiac failure PTs. Yeah. So this is something else. Yes, we accept classifications, and if it's mentioned as class 1, 2, 3, 4, we add it accordingly to the appropriate disease terms.
So the new KILIP followed the same, as you said here, either the KILIP classification, just like the NYHA, goes under the investigations. Yeah. The condition, KILIP class 1 is a condition, although it's not a result as such, it refers to this condition.
Yeah, and the KILIP goes to acute myocardial infarction.
Acute myocardial infarction. I have it here just to show you, summarize. We see clearly there the KILIP class 1, as you say, goes to cardiac acute myocardial infarction. Good. So, interesting. Our group differed from us there, and hopefully you've learnt something. The next example is atraumatic splenic rupture, and this is an interesting one because our submitter tells us that trauma is the most common cause of splenic rupture. However, in some cases it can happen without trauma. So this they call atraumatic splenic rupture in a wide array of age groups ranging from teenagers and young people. Commonly, they tell us the symptoms, and they say that the majority of causes are pathological, occurring in diseased spleen with 3 major etiology groups: malaria, idiopathic thrombocytopenic purpura, and neoplasms. So this is what they're asking for, a PT. For this, what would you do here? Would you add that one? Atraumatic splenic rupture. So, yes, that was overwhelming. You'd have a quick discussion on that one. Somebody's playing devil's advocate with their 13%, perhaps, but atraumatic splenic rupture. Would you add it? So let's see. Has everyone voted that wants to vote? It was approved, but not as requested. So why not? Why not? What happened?
We modified the wording because in medical literature it's most often qualified as spontaneous splenic rupture. That's the only situation. Sometimes we choose the medical more prevalent term. Yeah. But here we do have another example where you need to be very careful by coding. So we do have situations like with the splenic rupture. They can be spontaneous and traumatic. And the PT splenic rupture is not having the qualifier traumatic. It only goes as splenic rupture and primarily in to the injury sock. So we recently got as well atraumatic subdural hemorrhage. So because the subdural hemorrhage and subdural hematoma primarily go to the injury sock because most often they are traumatic of origin. So be careful and look whether your term goes primarily to the injury sock, but it's like with the atraumatic or spontaneous splenic rupture, which is not, it's more a bleeding problem, internal bleeding problem. Okay, I don't think we need to go to the splenic rupture now.
Okay.
Yeah.
So there we are, just explaining there are a number of causes that you agree that could be. So the next one, well done to the group there. The next one was a request for pulmonary aspiration. The rationale doesn't give us any description here, but it gives us a reference. So we can look and see what that reference provides, and it gives us the definition on the reference itself. Pulmonary aspiration is defined as the presence of bilious secretions or particulate matter in the tracheobronchial tree. So they've told us what it is through the reference. Pulmonary aspiration. Would you let me just make sure everybody who wants to vote can vote? Everyone with us on this one? Anyone else want to join who hasn't so far? Good. So do you think this one was added? More difference of opinion here on this example. Aspiration, pulmonary aspiration. Generally, our group agree. Again, it'd be interesting for the discussion to know why the people who say no, what their objection is. Let's see what really happened. It was approved as requested, and the proposal to add it was approved. So, Eva, if you want to tell us anything on this one?
Yeah, this I know why people voted for no. Because aspiration, and probably go to MedDRA and enter aspiration. Aspiration as such most often is used as a procedure, and we do have aspiration, pleural cavity, and so you can say the term pulmonary aspiration and aspiration as such are ambiguous and can refer to a procedure as well. So, but here again, I guess we do have the aspiration in MedDRA since beginning, and we may have had discussions as well about aspiration, and this is like what we have seen with the grams. Aspiration without any addition goes to the respiratory sock and means pulmonary aspiration into the tracheobronchial tree.
So I'm in the supplemental here, so people can see. I changed it at the top where it's now here. You see it switches from the release view of MedDRA, the screen's turned pink. This is the supplemental view when you're in the web-based browser. And this is how we can now see the LLT that was added. Pulmonary aspiration links to the PT of aspiration, and it's there, as Eva says, in the respiratory sock. So whether we agree or not, I can see there is there. I maybe because it's pulmonary and it would be harder to get that far down to aspirate, not like tracheal.
Since those are decisions made a long time ago, and again, aspiration is in MedDRA since 2.1 as a pulmonary aspiration in the respiratory sock and not as a investigation. First of all, if you have a conflict with placements, you always can get back to us, and then if a term is requested 3 times from different subscribers all over the existence from MedDRA, then we discuss first in our bigger medical team, and then we have experts, and sometimes we consult with the management committee. So it's not that we are judging all over, and we are not the only wise people. So, but aspiration is so important, and if we would say no aspiration, we say it's more investigation, then this may have a negative impact again. Yeah.
Yes, for the legacy. So it's interesting what we said. We can understand why our group were hesitant to add it, because we can see there that tracheal aspiration is already non-current as an investigation.
Yeah.
Yeah, interesting. Thank you there for mentioning, Eva, that the subscribers do have the option to appeal against your decision.
Yeah. And you see, we did have, since what Jane just mentioned, the aspiration tracheal is non-current flag. We had this discussion many years ago, and now we found our internal solution, and if you have problems and you see it different, you may flag in your database some terms where you disagree with the placement in MedDRA, and yeah, for clarification.
Thank you. And we've just had a comment from Martin saying, when you do code, for our coders, when you do code, ask yourself, is it the matter in the lung, or is it the procedure to remove the matter in the lung? And it is, those terms could be viewed as ambiguous, as you've just explained. So be clear that you understand what's being reported when it's reported, and query to the reporter if you need to. Yeah. Next one. Are we ready for the next one then? Difficulty closing hands is the next example. This is one, while difficulty making a fist may seem like an issue just involving the hands and arms, it turns out that grip strength problems may be a sign of a more serious issue. So they want difficulty closing hands. I'm not sure whether it's because they don't want it to appear like grip, or I'm not exactly sure on that one. What do you think? What do you think as a group? What would you advise? Should we add it? Difficulty closing hands. We've probably got some coders out there who can remember getting terms like this. Difficulty getting out of bed, getting out of a chair, difficulty with what do you do with those? So should we add them? Difficulty closing hands. No is the predominant decision there. No. And you're right, it was not approved because there's a variety of reasons. Anything to share on that, Eva?
Yeah, it's just too vague and unspecific, and dangerous where to put it because of so many potential underlying causes. So
thank you. So
I know reports come this way, but still nothing for MedDRA.
Not when it could have a variety of reasons. It's not clear, is it? It's not. It's not unambiguous. Comment there. It's not always an issue of muscular strength. It could be neural or tendon. So we don't know what's causing it. It's not even. You can't even say it's necessarily muscular or joint related. It could be the nervous system. Yeah, I agree. Next one. Then this is two terms here that I've put on the same page, but they would actually have been submitted as separate requests. The first was sensory processing sensitivity, and the second was highly sensitive person. I've put them together because they were requested in a batch together and they're related. People who have a sensory processing sensitivity are thought to have an increased or deeper central nervous system sensitivity to physical, emotional, or social stimuli. Another term for this is a highly sensitive person. Now, I didn't know that. To me, a highly sensitive person is maybe one of your friends that you're worried about hurting their feelings when you're too direct speaking with them. I didn't realize that's what highly sensitive person meant. So is it someone with a sensory processing sensitivity, with a deeper central nervous system sensitivity, physical, emotional, or social? I suppose that's meaning the same thing, really, and there's a reference for it. So what would you do with these two? Slightly different here. Would you add only sensory processing sensitivity? Would you add highly sensitive person? Or would you add both the terms? Sensory, maybe it does mean what I think, somebody that's very easy to hurt their feelings. 80% of people would add only sensory processing sensitivity, or more than 80%. Now, don't be swayed by your fellow attendees here. I see there's a shift. What do you reckon, Eva? Our group are only adding the one. You'll remember the discussions with the rest of the team on this one. So the final action was to approve as requested for both of them. If we have a look there, the first paragraph deals with sensory processing sensitivity, and the second one is highly sensitive person. They were both added. The lay expression will be added as a synonym LLT to the PT sensory processing sensitivity. So tell us more.
Yeah, we had a long discussion because we had different opinions as well. And finally, searching all the literature, we always do, we came to the conclusion, yes, it is valid. And yes, high sensitive person is a valid synonym. And then we already had an PT sensory processing sensitivity, no, another one, sensory overload, which was placed somewhere else, and then we moved it to the same HLT. So, yeah, here.
This is the screenshot. So this is what you mean, Eva. I've missed a few out there. So they are all under the same HLT of sensory abnormalities, not elsewhere classified.
Yeah, and we didn't judge it as psychiatric. It really is a central nervous system sensitivity to certain stimuli. Of course, if the stimuli are emotional, then it affects the psychiatric as well. But as such, we kept it read in the neurological or nervous system disorder SOC.
I think that's interesting what you say there, the placement, putting it in nervous system. That's shown one where you really do need to do your research and discuss it. Interesting. So, and the last one we've got today is algid malaria. And the company had received a report of algid malaria for coding. They're telling us that it's a complication of malaria manifesting in a state of circulatory collapse. So it's a complication, but it has a name in itself. Although rare, it can be rapidly fatal with a high mortality rate, believed to be caused by a release of tumor necrosis factor, impaired microcirculation, and metabolic acidosis. So good rationale again, explaining exactly what it is, how it manifests, what causes it as a complication of malaria. But important by the looks of it. Would you add this one? Yes, seems like the biggest decision there from our attendees is that yes, they would. There's some discussion needed for the 20% who don't agree, but let's see what actually happened. It was approved as requested. This is interesting, Eva. Tell us what went on in the discussion there.
We didn't have a long discussion. That's a clear concept and a very severe complication. And it was, of course, the primary link goes to the infection SOC because it is a malaria infection. But then we added second HLT to the circulatory collapse and shock. And furthermore, it goes in at least one SMQ for toxic shock situation, maybe even in two SMQs. This is quite new, and we didn't have the SMQ consensus on this.
So what I thought was interesting, Eva, on this one is we say that we don't have conditions where one is a due to, but we do have where it's a complication within the actual progress of the disease, don't we? It's the actual condition itself progressing to another state. And this one, a very severe situation. So it's different from where one condition leads to another condition.
Yeah, you mentioned the due to or associated with, but algid malaria is a severity and different from if only you have a certain type of malaria. And it's a set expression. So if we have set expressions, then we accept them and don't say, we do not say it's a circulatory collapse due to malaria. So that's the case. And we had many requests for COVID-19 associated heart failure, COVID-19 COVID-19, yeah, whatever. We didn't accept them all. So, because it's associated with a disease, something else. But here, algid malaria is the severe stage, and complication of malaria.
Thank you. And it's recognised, as you say, it's got a term for it. So that's thank you. And there it is. We can see it there. As you said, it's in the infections, as you would expect with malaria, but it also has a link to the vascular for the circulatory collapse. Again, something you'd expect. So shows the multi-axiality placement there. Thank you, Eva. So overall, I think, as we've shown, it's all about working together, and we would say only request the terms you need. We will make the related changes. So if you ask for a term and there's an abbreviated form, our team may well decide to add that as an LLT. We add the English and American English spellings, British English and American. You don't need to request them separately, and you don't need to request both the LLT and the PT. I remember when I was first in the industry, I thought I was doing you a favour, Eva, by requesting both of these, the LLT and the PT, both of them. But actually, you would just reject one, because we only need our submitters to ask for the PT or the LLT, and if it's appropriate, the team will add the other one. Similarly, with the qualifiers, just ask for what you want. If you want increased as a lab result, ask for the increased. And when our medical officers do their research, if they feel there's a need for the decreased, high, low, normal, abnormal, they will be added. If they feel that they would be useful and they're commonly reported. Couple here that we did have requested this time, just as a couple of examples of the sort of things that can go wrong when people submit. Here, the existing concept was already in MedDRA as a synonym. The proposal was to add breast cyst aspiration, and it wasn't approved because there was already an LLT of fine needle aspiration of breast. So similar, slightly different wording, but it is clearly the same concept. So that's why that one wasn't approved. And also the point I made earlier that MedDRA has evolved now over 23 years, and terms are not replaced for consistency. It would make MedDRA too unstable if we were to go through and do a wholesale review of changing things for spelling, for wording purposes. Here are a couple of examples. We received a request to modify carcinoid tumour in the large intestine with carcinoid tumour of the large bowel. So they're asking for the synonym, changing the wording, and that wasn't accepted because there's no need really. We've got the concept in there, the wording is fine. Echinococciasis of bone, the request was for bone echinococciasis. I hope I've pronounced that correctly. Apologies if not.
One aspect you have to keep in mind is we do have many other translations. So whatever we add in English needs to be added in all the other languages as well. And some languages do not make a difference, but for example the British and American spelling, or they only have one version for the large intestine, maybe they don't have the bowl. So everything which is cosmetic and nice to have is not necessarily what we do. In respect to the word order, new terms will be added in the natural word order and not in parallel to existing old reverse word order. So, but think on impact on all the translation work for whatever for you in your database for automated coding may be nice to have, is bringing a huge impact on translations as well. So we try to avoid redundant additions of LLTs for synonyms or word orders.
Thank you. Good. So the overall guidance, tips for high quality change requests. high quality being ones that are highly likely to be approved, is to provide clear rationale and medical references, check for existing supplemental terms. And I'm going to, if you stay with us, I'm going to show you how you can do that in 2 ways. Use the WebCR to review if similar terms have been submitted previously. That's something we'll show you. And refer to the MedDRA introductory guide on the website. And as we've already mentioned, only request the terms you need. Don't do gap filling. Don't sit when you've got a quiet afternoon and look through some medical references, see if you can find something that you don't have, that we don't have in MedDRA. Only request them if you actually need them. So that's what we would say, to keep MedDRA as stable as possible. And then we would just ask you here, the last poll asks you, hopefully you've enjoyed this session, and how do you think this will best help you? Is it in understanding the rationale for the change? Some of you mentioned the overall process, or understanding the IMO's decision making. That's what we tried to share with you today by Eva giving us her insights into the discussions that took place. So I'll leave you to vote on that one while I'm going to go to the browser. Let's go to the browser first here. So this, as we were mentioned, is the supplemental view. I can take it back. If I go back here, you see the drop down. I'll go to the release view, and it's up the top right-hand side here, and that's where I change it down with the drop down to supplemental. And you see the changes very clearly there with the dotted line around them. So that's the first way you can see for supplemental changes. These are changes that have been approved for future release in a next version of MedDRA. So I'm going to go now to the website, and I'm going to show you a couple of things. So on the downloads page of the website, you've got, let me just log in. You've got the supplemental releases here. We've got MedDRA supplemental releases. Now, weekly, our team post their decisions. This is a textual document. It's a PDF format or the ASCII format. And if you're interested, you can look on a week-by-week basis what's actually been added. So if you're just looking out of interest, you can review each week what Eva and the team have agreed. And there's the comprehensive changes. Some companies use that in preparing for versioning upgrades before the release date. So that's another thing there to point out. Then we can, how to use change requests. If I take you there to the change request page, you remember I had a slide of this. And I'll go to the Submit Changes WebCR here. I'll log on with my own login again. And here's the tool. So this is what you would see. This is how you do it. You can look at the change request history here, and we can look at a term. Oh, any examples, Eva, you want to give us? What do you think we can look for? Now, I use wildcards. I would go for, let's go for angina. We could have gone for cramps. Is that too many? Will we have too many?
No, it's fine.
So these are all the various change requests that have been added, submitted in the past. And we can see, as you said, I asked for one which has got a great many. How many times have people asked us? There are 10 pages of them. Different, changing status of angina, moving it from one to another, promoting terms. You can see them all listed here. And if there's, let's most recent.
Jane, angina is always an example I'm using in face-to-face coding sessions as an example for why angina is still in MedDRA and where it is, because angina in French, for French people or for Germans, means the angina tonsillaris, but for other people in Britain and American, it means angina pectoris. So yes, it is non-current. We suspended it because it's so often used, and we kept it under the more severe scenario, which is angina pectoris. So angina is having a long history.
Long.
it was moved to pain because it's Latin indicating pain. So that was a long way for angina, only angina without any addition. Yeah.
So here's the most recent request to make it non-current was back in version 19, so 6 years ago now, time goes. And this is, as you said, Eva, it was suspended and then eventually rejected. And here's the rationale you can see for that. So we go back, we can do this, we can search for any, we can look at our cramp term, we can, any of the ones we've done. Let's look at our Laryngocele, just so to give you an example. With the wild card there, you can see.
Yeah, not so many. Yeah.
Not so many. This is the most recent one we've just seen. It's been approved to go into version 25.1 to add a new P, acquired Laryngocele, and we can see the details here of exactly what I showed you in the slides today. There's the rationale with the final comment. We don't see the rationale from the subscriber, but we see our team's decision. So there we go. That's the other way of doing that. And you do that through, just a reminder, you do it through the website, how to use change requests. And this is where you have the link to the WebCR tool. And it's in the WebCR tool that you submit your changes. And you can look at the history. And that's where we also see the change request information document and the WebCR quick guide. And you can see the complex changes there in all of that. And it's the downloads to see the supplemental PDF that I told you. Anything else to add, Eva? That's all I wanted to share with the group today.
Yeah, maybe if people send in change requests, if they have 10 change requests, they probably, we prefer that they send in as a batch and not each single change request, because if some change requests go single by single, but they are connected, and maybe the first 3 CRs get to me, the second few go to the Spanish colleague, so it's disrupted. If change requests belong together, then please edit as a batch and not send in single CRs.
Yes.
Maybe if you can show how to do it.
Yes.
Oh, no.
And I can show you through WebCR, you mean, yes?
Yeah.
WebCR, I can show you. So here's the tool. Here's our, this is the home page for WebCR. This is where mine come up as internal, but that's because I'm using my MSSO account. So you would decide, are you adding a term? It gives you the option. As Eva said, you can either choose to just add a new term or specify is it a PT or an LLT. And if I go for a PT, it tells me that optionally I can give the placement, primary and secondary, if I know it, I may have preferences for where I think it should be, and here's the box for the justification. So when you do that, you save your change, and what you can do is you can go in and out of the tool over a period of time, adding them, and then maybe once a month, one of your team will have the responsibility to review them and submit them as a batch. So as Eva says, don't feel you have to send in every single term singly, because it would then be a batch with only one term in it. And the batches are distributed among our team. So they, as Eva says, you might find that your terms are split. If we think of the epilepsy we saw with the gene mutation, it may be that Eva reviewed and gave her opinion on one, and Tomas did the other one. So when you have 2 terms that are related, please don't submit until you've entered both of them. Is that what you mean, Eva?
Yeah.
Good, thank you. That's a good point. I forgot that. Thank you. Any other questions from the group? I'm not seeing anything new. Otherwise, anything else to add, Eva, before we say goodbye?
No, I'm happy.
You're happy? So this is a summary of what we've done today. We've explained it, outlined the process, given you some examples, and thank you for your participation in that today. It makes it a lot more interactive and enjoyable for us. Here are some links for you, the website. If you've got questions, you can email us at the MSSO Help Desk about anything you may have. the frequently, and if things come in relating to change requests, if there are questions, I would forward them from the help desk to Eva or the team. There's some information on our frequently asked questions section of the website, the links to the browsers there as a reminder to you, and then the change request page that we've shown you today. There's the support documentation, more training, and there's our contact page. So you can join any of our social media groups through WeChat or WhatsApp, and you can contact us through a contact page that's also on the screen, or even live chat now. You can do a pop-up live chat if you want to speak to somebody live. So that was all we were going to share with you today. Thank you for your attention. We're on time. It's just coming up to 10:30 here. So thank you. I hope you've enjoyed it. Thank you very much, Eva, for your collaboration. It's always great to collaborate with you on these sessions. And I look forward to seeing some of you at our future webinars later in the year. Enjoy the rest of your day. Stay safe. Bye-bye. Bye-bye, everyone.
Bye. Thank you.